So after like 3 days of extreme cold, especially last week over Valentine's and stuff, today is almost 50 degrees. It's pretty warm out. Some bipolar weather right here. We're almost done with NBME 21, so I wanted to wrap this up, get it done with this weekend, and then throughout next week finish up the full mastery playlist with finally wrapping up the respiratory topics and discussing a few of the topics I've been getting a lot of emails about, like advice for what to do about passing NBME, how to use other assessment exams to understand if you're ready for step 1, or even beginners emailing about, good study advice and stuff like that. So it often ends up being a really long email to type out, and I figured a long time ago that I should have made a video about this already, but I just have not had time recently. So let's get this out of the way. We're up to actually number 141. So remember that if you're referring to any question that I do, if you're referring to any one of these questions, make sure you either reference the number down here or just put the timestamp at whatever time I'm talking about it. And then you can ask anything you want either during the live stream or if you're watching this later, of course. Just put the timestamp there and then ask whatever it is you want to ask. And of course, as usual, these page numbers are for my own annotated first aid. And if you are interested in buying any of the products I use on the video, you can feel free to shoot me an email anytime. That's down there in the video description. So let's knock out another 20 questions. So right here, question 141. A 25-year-old woman develops increasing shortness of breath with exertion 2 weeks after the birth of her first child. Okay. So immediately when you read such a thing, right, there's two things that should come to mind. And this was actually a really, really interesting question. I've spoken about this specific question many times with students when I talk about cardiovascular. But generally speaking, let's just pause right here. So if you read this first section right here, right, everything that happened right there, that's actually pretty indicative of something else that's more common than what this question itself is about. So one of the things that can occur when you learn about this in reproductive is something that has a cannonball metastasis to it too. Let me see, where do we find, yeah, right here. So right after discussing moles in the book, they talk about this topic of choriocarcinoma, right? And this thing is a malignancy of trophoblastic tissue with no chorionic villi, and this can occur in either during or after pregnancy in either the mother or the baby, right? So there's 4 different scenarios here: during the pregnancy or after the pregnancy, and then 2 scenarios of in the mother or in the baby. So all of those are things that, this should have been the first thing that came into your mind when you read that first sentence, that this woman is having some kind of respiratory issue, right? And potentially even cardiovascular, because of course shortness of breath is also related to heart failure and, blood backing up into your lungs. But initially, breath, you immediately think respiratory, and then you think of choriocarcinoma as a potential possibility. But then you keep reading, right? So the next thing says physical exam shows JVD, evidence of edema in the lung bases, mild hepatomegaly, and mild pitting edema in the lower extremities. Everything in this second sentence, all of those symptoms that they're talking about, are symptoms of heart failure. Right, so now you're thinking, okay, this isn't about choriocarcinoma, and this definitely isn't a question about respiratory issues. Now it's an issue about cardiovascular issues. And of course, you confirm that by reading the last sentence. This is a 3-sentence question. Which of the following cardiac abnormalities is most likely present at this time? Now, this was a question about dilated cardiomyopathy. Okay. And answer choice C is that answer, 4-chamber dilation. Dilated cardiomyopathy, generally speaking, you memorize the A, B, triple C, D, right? A, B, C, 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 D. You memorize that aspect of things, and then that's generally all people tend to remember. There's actually a lot more than just that to dilated cardiomyopathy, though, right? Dilated and hypertrophic, as well as hypertrophic obstructive, all 3 of those are extremely big topics of cardiomyopathy. But the biggest topic is definitely dilated cardiomyopathy. And you can see how alcohol, wet beriberi, coxsackie, cocaine, Chagas disease, and doxorubicin are easy to memorize with the ABCCCD stuff, right? There's multiple reasons for you to be able to memorize all of them. and they're all really big topics that pop up all the time. But there's more to it. There's also hemochromatosis, sarcoidosis, thyrotoxicosis, and then what our question is about, peripartum cardiomyopathy, right? It's in first aid. So this question didn't just come out of nowhere. However, you might have read this peripartum cardiomyopathy thing whenever you studied cardiomyopathies, taken it for granted, not really thought much about it, and moved on, almost as if this didn't even exist in this paragraph, right? A lot of people do that. When you're reading, that's the core difference between active reading versus passive reading, very much like hearing versus listening. So active reading, you're supposed to think of each one of these things whenever you see something like this. And if you thought about what is peripartum cardiomyopathy even like, what happens in it, what could be even, one of the causes of it, then you would be good to go for this question easily. On top of that, there's really no reason for you to pick any of these other questions. There's no reason for this 25-year-old woman to suddenly have shortness of breath after delivery due to some asymmetric septal hypertrophy. That's just not, why would you have septal hypertrophy? Why would any one septum become hypertrophied? It's not going to happen. Endocardial fibroelastosis, that's also on this page, right? It's under the restrictive and infiltrative cardiomyopathies. This thing is fibrosis and excessive deposition of elastic tissue in the endocardium in the first 2 years of your life. And this is a 25-year-old woman, so it's not something that can occur. Get rid of that, right? Lymphocytic infiltration of the myocardium. Again, she doesn't have a viral infection, so there's no reason to pick that. Nothing in this question is telling us she has a viral infection. And then myocardial disarray, that's hypertrophic cardiomyopathy, right? That's exactly what you look for in hypertrophic obstructive cardiomyopathy, right? Sarcomeres, myofibrillar disarray, and fibrosis. Now, be careful with this topic too. This is a huge one. HOCM, hypertrophic obstructive cardiomyopathy, is the autosomal dominant thing that kills athletes, right? Really young athletes died running or something, doing something athletic. That's different. Hypertrophic obstructive cardiomyopathy is very different from these other things, such as left ventricular hypertrophy, which can be due to either chronic hypertension or Friedreich ataxia, right? Of course, left ventricular hypertrophy here too. It's one of the defining features of HOCM, but HOCM is a different case scenario. Then you have chronic hypertension, which of course makes your left ventricle become stronger in efforts of pumping against an aorta that's just not going to let blood go through it, and Friedreich ataxia, which is defined by having cardiac issues. It's one of the major symptoms in Friedreich's, right? As I talk about it right here. All of those other answer choices didn't really fit, and there's a bunch of shit that causes dilated cardiomyopathy. Just pick C, you move on, and that's really all it was. All right, so not a ridiculous question, actually a very good question, if you just straight up remembered that peripartum cardiomyopathy is one of the things listed here. All right, so that's it for that one. 142. 20-year-old premagravid woman at 12 weeks gestation comes to the physician for genetic counseling. She underwent repair of a unilateral cleft lip as an infant. She had no other abnormalities. Her maternal great uncle had a bilateral cleft lip and palate. All right. He also had no other abnormalities. She is concerned that her child might have the same condition. Which of the following is the most likely mode of inheritance of this disorder in this patient's family? Now, they did a very cunning thing by mentioning a maternal great uncle, right? So that they can kind of make you start thinking of something X-linked, possibly, right? Because some male got it in that one. But they did give away the fact that a woman, right, at 12 weeks gestation comes to a physician for genetic counseling because she actually herself also underwent repair of a unilateral cleft lip as an infant. So it occurs in women and men. So there's no reason for you to really pick X-linked there per se. And then just the whole concept of cleft lip and cleft palate, you should know that something like that is multifactorial. It's not actually something that's autosomal dominant or recessive or whatever in a way that you inherit it. It occurs by mistake, right? It occurs by mistake. So this was just actually whether you know it or not kind of question. It just really, really easy. There wasn't anything crazy conceptual about this question. Yes, everything has to be looked at, understood, and remembered, right? Mainly everything has to be understood. That's the most important part. You have to understand all of that. In a pregnant woman, getting dilated cardiomyopathy isn't exactly that far-fetched either, right? And even if you don't understand everything, the main concept is you should know enough to be able to pick the right answer choice. That's the most important thing. Like as far as test taking strategy is concerned, you should know enough to be able to pick here C rather than anything else, because those other answer choices, like I already explained, would not fit the scenario this woman is undergoing. It just doesn't make sense. The easiest answer choices to knock out were myocardial disarray, lymphocytic infiltration, because you know there's no viral infection, or HOCM over here. And then if you remember, endocardial fibroblastosis occurs in infants basically, or really, really young children. You can't pick that as an answer choice at all. And then you can knock out asymmetric septal hypertrophy, because that wouldn't explain all her symptoms. Alright, so now we have a pharmacology, GIT Pharm 143. A 53-year-old woman with GERD comes to the physician for a follow-up exam. Dietary changes and stress reduction have had no effect on the frequency or intensity of her symptoms. Physical exam shows mild epigastric tenderness. Which of the following drugs is the most likely to be effective in both relieving this patient's symptoms and promoting healing of her esophageal mucosa? Now, they only added this promoting healing part to it to kind of make you pick misoprostol. They wanted you to be like, oh, okay, they don't want to just relieve the symptoms, they also want to heal it. So let's give a medication that does something other than omeprazole, and you would pick misoprostol, right? That's something that can easily occur in a student, and it would be a mistake. First things first, you can definitely knock out bethanechol and metoclopramide, because those two medications have nothing to do with the GERD that this patient is presenting with. Then you have famotidine, right? And the dean in the end is supposed to remind you of dining, right? So food. If you are still at that stage where you're trying to memorize medications by doing something like that, but eventually before you're taking step one, you should be at the point where you can just look at a medication's name and know exactly what it does. Your H2 blockers, remember, which this is different from H1 blockers that you're going to see later on in respiratory. Your H2 blockers, right? Dinner for two, all of these medications, they are just H2 blockers. Only this one. This is the only thing they block. Right? But then, of course, acetylcholine, gastrin, and these other GQ-using pathways can still cause acid release. So famotidine is almost never an answer that you pick. H2 blockers in general are almost never an answer for you to pick. Right? It's only for mild esophageal reflux, not for actual GERD that this patient is presenting with, and she looks really tired of it. You could use it for efforts of helping gastritis, help someone with peptic ulcers, but generally speaking, these medications aren't all that good, right? And never pick cimetidine or ranitidine as an answer choice, because both of these decrease renal excretion of creatinine, so your creatinine goes up, you can have some other issues with it, right? It's not good stuff. The safest ones are the famotidine and nizatidine, but again, they're not that effective. These medications are not that good. They're just an adjunct medication at best, if anything. So from there, you're just left with D or E. Misoprostol, you know, is obviously some kind of prostaglandin thing. Right? Omeprazole heals gastric and duodenal ulcers more effectively than misoprostol, whereas misoprostol was more effective in patients with erosions alone. This patient has GERD. Misoprostol, what I actually fell for, and I picked it, I fell for that mistake, is for NSAID-induced ulcers and erosions, right? When I was revising this, I felt really upset that I even picked it, that I even fell for that mistake, because misoprostol, you know, they did a great job in the way they worded this question to make you kind of fall for it, but misoprostol is never an answer choice for GERD. You don't think of misoprostol when you think of a patient coming in with GERD. You think of omeprazole, maybe the famotidine and all those things. So omeprazole was the only answer choice to really pick here. By relieving the symptoms, you automatically promote healing, right? Because now you don't have that acidity causing more and more damage, so you have self-healing of that lower esophageal mucosa. Misoprostol is for protecting, right? You see it later on down here, this one, misoprostol, right? Prevention of NSAID-induced peptic ulcers, because NSAIDs get rid of prostaglandin production. So you can give misoprostol, which is a prostaglandin in itself, and it'll serve as a mucus barrier, right? So that's nice and all, but not exactly what we're looking for our patient. So never fall for stuff like that. NBME does it more often than step one, but Step 1 does it in more cunning, different ways, different cunning manners than NBME. NBME acts in a cunning way, almost in a very childish way, where it kind of pisses you off. Because I definitely got very upset when I saw that I fell for that, right? So this was omeprazole, the most common medication that we give to pretty much everyone who comes in with any kind of gastric reflux or heartburn, anything like that. This wasn't so bad. This question, 18-year-old woman comes to the office because of a 2-week history of pain in her right elbow. She's on the tennis team at her high school and has practiced for 5 hours daily during the past month. Physical exam shows tenderness over the lateral aspect of the right elbow. Right, so the lateral aspect of the right elbow, so right here somewhere. Right, and this patient most likely has an inflammation at the origin of which of the following muscles? So you know that this is going to be more so related to lateral epicondylitis, right? They're talking about the lateral aspect over here. The answer here was B, your extensor carpi radialis brevis. The reason you would easily pick and only pick this answer choice and nothing else is because when you think of all the muscles that connect down here, as you can see in the picture, these are all upper forearm muscles, if anything, right? And they're all extenders, right? Or extensors, right? They're all extensors. You do not pick a flexor. The pronator, you know what it does, right? So pronation is when you take your hand and make it face down. Supination is going up. That has nothing to do with, you know, a muscle that inserts at the right epicondyle or lateral epicondyle. And then palmaris longus doesn't fit the question either, right? Because if you don't remember where palmaris longus is, then you can at least understand that it must have something to do with maybe the palm, and then just call it a day right there. But palmaris longus is over here, right? So this would be on the medial epicondyle of the right hand, right? Medial epicondyle of the right hand, and it makes sense because you can think of palmaris longus as you to look at it, you would actually have your palm coming up, right? So like you never really talk about your medial epicondyle with your hand facing down. You talk about it like this, and then you talk about the other one with your hand facing down. Right, so this is like generally how we move comfortably. So palmaris longus, flexor digitorum superficialis, again, another muscle that's a flexor, so it does not fit. Now, if you don't have all of these muscles of the arm and forearm memorized, that's something that you spend time on every other week or something until you do have it down, right? Because you do need to know it. You do need to know where all your muscles are. Of course, first aid doesn't have all those muscles there, but you can always find it, of course, through netters, right, with perfect pictures like this and getting everything down. So the main ones you really want to know are all the muscles in your upper arm, right, and then of course all the muscles in your forearm. Very important to know them. And you should be able to talk about them just by using your own body, right? You should be able to talk about where they are. Some people, you see how these yellow, green, red, and blue, right, those muscles are? People talk about it with their hands like this. You know, they'll be like this, and they'll have a name for each one just like that. Then they can put it over here, have a name for each one like that. All kinds of ways of doing it. There's many YouTube videos about all of that. You should be able to mention all your muscles pretty easily, right? For the arms and forearms. And then when it comes to the legs, it's a whole different scenario there. The legs have many more muscles than our arms do. But this is something you're supposed to spend ample time on when you're studying musculocutaneous. As you can see in my first aid, I've had to add so many pages just to add all the arm stuff. Then the knee exam part of first aid came, and I had to add a bunch of more pages to talk about all the leg muscles. As you can see from here on, I'm using two different resources here. The charts are from Netters, and these are from teachmeanatomy.com, which is an excellent website that I totally recommend if you're trying to master and learn where all the muscles are, right? And then, of course, right after that, to tie it all up, you would answer a bunch of UWorld or AMBOSS or USMLE RX, whatever QBank you want to use, related anatomy questions, musculocutaneous anatomy questions. Sorry, musculoskeletal, musculocutaneous, yeah, anatomy questions. So this was just lateral epicondylitis in this 18-year-old girl because of B, extensor carpi radialis brevis, insertion over there. So, yeah. This one was a very nice question from early cardiovascular. 38-year-old woman comes to the physician because of a swollen, painful calf for 2 days. The moment you hear that, especially in a female patient, you think of DVT of some sort. She gave birth to a healthy term newborn 5 days ago, and you know that pregnancy is pretty hypercoagulable state, right? Physical exam shows pitting, edema, and tenderness with dorsiflexion of the foot. Now, the reason you know pregnancy is a very hypercoagulable state is because delivery is a stage where you bleed a lot, so the mother is ready for that bleeding stage by being hypercoagulable. So that's something you can always understand and remember. 1 day later, she has a cerebral infarction with hemiplegia. So we established in the beginning that she most likely had a DVT, and now she's having a cerebral infarction. But what is the actual most common thing that occurs after a DVT is that it could be a pulmonary embolus, right? But this is not going to the pulmonary circulation. It went to her systemic circulation and entered her head. So immediately by understanding that it didn't go into her pulmonary circulation, and rather it instead went into her brain, systemic circulation, which they do a good job telling you, right, in the next sentence, passage of an embolus into the systemic circulation is most likely to occur at which of the following locations. Immediately you know this is a question about a paradoxical emboli, right? It's paradoxical because it's not what you expect, and it doesn't make any sense. The only way it could occur is something's not normal, and then they were nice enough to put the answer choice right there, patent foramen ovale. They didn't try to pick any kind of tricky way of putting an answer choice. You have patent foramen ovale, the stuff is going to go into the left heart rather than into your pulmonary circulation, and then that's generally all that happened there. So this is discussed in first aid, actually in embryology, right after they talk about, right, so the first page right here, right after they talk about something that you should be able to describe without the book, septation of the chambers. Right, so if the septation occurs and you make a patent foramen ovale and it does not close, right, then you can get something called a cryptogenic stroke, which is also the same thing as a paradoxical, well, not the same thing as, the cryptogenic stroke is a result of a paradoxical emboli, right? A venous thromboemboli that entered systemic arterial circulation, similar to something that also can occur in an ASD, right? So something went from the right atrium into the left atrium rather than going from the right atrium into the right ventricle and then entering pulmonary circulation and causing a pulmonary embolism, right? So that's what occurred in our patient, and this was also a pretty easy, straightforward question. 146, a 50-year-old man has had progressive dyspnea on exertion over the past 6 months. He now has dyspnea at rest. He has had a persistent dry cough since having an upper respiratory tract bacterial infection 1 year ago. Examination of lung tissue obtained on biopsy shows chronic inflammation and fibrous thickening of the alveolar septa. Which of the following is the most likely diagnosis, right? So everything they're describing here is pretty indicative of a restrictive respiratory disease, not an obstructive one. He doesn't have COPD or any of those other major things, right? So this question was just testing that we knew the other names of pulmonary fibrosis, right? And they were tricky with it. But this is actually in the book too, I believe. So answer choice E, usual interstitial pneumonitis, is the only answer choice you could pick for this question. And that is actually just idiopathic pulmonary fibrosis, which can occur to anyone, right? Anyone who has had, especially anyone who has had chronic inflammation, which then eventually leads to fibrous thickening. And they were very nice in describing that, right? The diagnostic sentence in this question was examination of lung tissue obtained on biopsy, which is diagnostic, shows chronic inflammation and fibrous thickening, right? And fibrosis is this, right? But you would have to know this other name. Now, these other answer choices, chronic bronchitis, emphysema, right? Those two, and then diffuse alveolar damage, that's going more towards obstructive lung disease stuff. It's not what we're looking for. And sarcoidosis, we didn't have enough in this question for you to pick sarcoidosis of the lungs. Not enough was given. They didn't give you anything sarcoidosis related. Bilateral, you would know maybe bilateral hyaluronopathy or something, but again, that's not being given in this question. So tricky question, but not that difficult. Usual interstitial pneumonitis, very interesting way to term idiopathic. Let's take a look at it real quick. Idiopathic pulmonary fibrosis, which can totally occur in anyone for any reason, Right, so I did end up adding it into the book. I think, let me see. Did I write down where did I put it? Oh, I think I put it as a question somewhere else, but I do want to write it here too. So this one right here, idiopathic pulmonary fibrosis, is what they're terming as usual interstitial pneumonitis. Okay, and you got to make sure that you understand this can occur in anyone who has fibrosis. That's all they described in the question. Nothing else. Right? The biopsy is indicative of a diagnosis. Pick it correctly. 147, a screening program is instituted for detection of vaginal chlamydia trachomatis infection among first-year women college students. At the initial screening, evidence of the C. trachomatis infection is found in 500 of 2,500 students. 1 year later, screening shows vaginal C. trachomatis infection in an additional 200 students. Which of the following is the annual incidence of C. trachomatis infection in this population of women students? So you want to take this kind of question very straightforward. Don't get intimidated. Don't get worried because you didn't know the answer as soon as you finish reading the question. It's a math question. So now that you finished reading the question, you know what's happening. You read everything that's happening in its English, so you know what's happening. You go ahead and put it into perspective now. So the first screening gave you the prevalence, right? Because that screening checked how many people had the disease, not how many new diseases there were, but how many people had the disease or had the infection. So the first screening gave you the prevalence, and that was 500. Now we need the incidence of new cases. So the next year, they checked how many new cases there were, and that was 200. This means 200 new events took place in the second year. Now, the mistake would be your denominator. You want to make sure you no longer count people who had the disease previously. So that means that your denominator, your total number of students of 2,500 students, is now only 2,000 students, because incidence is new people with disease out of people who are at risk of getting the disease, which means you have to take out people who already have the disease. Right? So your new denominator will be 2,000, and 200 out of 2,000 is just 10%. B. That's it. Right. Let me see. If you had not done that and you put 200 over 2,500, 2,500, then you would have picked A, 8% as an answer choice. Right. So that's a very tricky thing that you want to make sure you understand. So your new denominator is 200 out of 2,000. Right, all the people at risk, not the total number of people. Prevalence is what looks at the total number of people. Incidence looks at all the people that are at risk. This was a question about Enterococcus faecalis. This is the sketchy micro image for Enterococcus faecalis. And this is the story with it. Let me see if it, oh yeah, it definitely fits. Right, so a 75-year-old man has fever, back pain, and pain on urination. So he's extremely old, which at the same time, for a 75-year-old man, you can assume his immune system isn't exactly doing the best, nor is his spleen working the best. Those are things you can generally assume. You don't have to make it a solid fact, but you can generally assume maybe his immune system is not working, maybe his spleen is not working too well. Fever, back pain, pain on urination. He has a long-standing history of prostatitis, okay? Gram stain of urine shows gram-positive cocci in chains, which immediately knocks out a couple answer choices. Like, of course, you can't pick Staph aureus anymore because they are not in chains, right? Staph aureus is like grapes. Which of the following bacteria is the most likely cause of his illness? You can also knock out Strep pyogenes. You can knock out Proteus mirabilis. Klebsiella generally causes more like pneumonia type stuff in people with hospitalizations, right? Nosocomial pneumonia, for example. So that's not going to work. E. coli is a trick answer choice here because, of course, that's the #1 cause of UTIs in many people, but it would not be related to having, prostatitis per se. So because they described gram-positive cocci in chains, you were able to knock out many answer choices and just come down to A. Right? That knowing the gram stains is a very, very important aspect of getting microbiology questions correct. If you check all the other bugs on this answer choice list, all the different answer choices, you'll see that they're either not gram-positive or they're not cox-ion chains, or they have nothing to do with causing the symptoms this patient is presenting with. Now, prostatitis, that's a really big topic too, right? And they do talk about that. So right here is the last topic, is the prostate in reproductive. And prostatitis is related to E. coli, so that's why they put that answer choice there. Right? In older men, the most common bacterium is E. coli. In young men, considers chlamydia or Neisseria. Chronic prostatitis can cause other major problems. So E. coli was a very mean answer choice to put here, but they were nice enough to tell you it's gram-positive cox-ion chains, so there's no reason for you to pick B. All right. Next question. Oh, let me just close this real quick. Okay. Well, this here is just to help you remember all the things that you're supposed to know about Enterococcus. So if you don't know everything about Enterococcus, you want to make sure you take a look at this. And if you haven't done sketchy micro, then this image won't necessarily make much sense to you. But this outline here is kind of telling you what the sketchy micro image is really talking about. There you go. Perfect. Here, number 149. Another list of answer choices with fractions, so don't get intimidated, just remain calm, read the question first. 46-year-old man comes to the physician because of a 2-month history of prolonged bleeding from minor cuts. Physical exam shows hepatosplenomegaly. Lab studies show mild anemia, thrombocytopenia, and leukopenia. Bone marrow shows lipid-laden macrophages, and as soon as you see lipid-laden macrophages, you're immediately starting to think about all your lysosomal storage diseases. If the incidence of this disease among Ashkenazi Jews is 1/900, which of the following is the approximate carrier frequency of this Mendelian trait in that population? So the reason they even gave you this 46-year-old man and his story is so that you can identify the way this disease is kind of spread. And this disease or this condition is autosomal recessive, right? It's a lysosomal enzyme deficiency, which are mainly autosomal recessive. They're not even asking you for the diagnosis, but they're telling you with any autosomal recessive disease, if this autosomal recessive disease has an incidence of 1/900, what is the approximate carrier frequency? So immediately, it's a straight up Hardy-Weinberg question. You have to understand that they basically gave you Q squared, because that's what incidence is. So Q squared is 1/900, which makes Q 1/30. Now you know P plus Q equals 1, so you can do 1 minus the 1/30, and you get what 29/30, right? And 29/30, right? When you get something like this occurring, when you do a question and something like this occurs, that the P value is 1/29, or sorry, the Q value is 1/30 and the P value is 29/30, you can at this point kind of just treat the 29/30 like a 1, depending on the math you're doing, right? Now, to figure out the carrier frequency, right, you would need 2PQ, right, or 2QP, whichever thing. And when you do this multiplication, right, this becomes a really rather difficult kind of multiplication to work out, but if you go ahead and try it, you solve it, you would get 1/15. But the only way to really be able to do it is to estimate, right? Estimate the 29/30 to just be 1. This part, replace this with 1. So you're just going to be doing 2 times 1/30, which is 1/15, and that's answer choice A. Right? Almost always. Now, I can't say always, but I want to say always. But almost always, you can replace some kind of P that looks like this, 29/30, 499/500, etc., etc. Any place where the numerator is just one number lower than the denominator, you can replace that with a 1. Okay? It doesn't work the other way, though. You can't replace 1/30 with a 0, because 0 is very controversial. You would make the whole answer choice 0, so don't do something like that. But this thing is definitely very, very close to 1, so you just make it 1 for easier math purposes. Very easy question, very straightforward question. They just wanted you to be able to get the Hardy-Weinberg stuff down. Now, as far as lysosomal storage diseases are considered, that's also something you're supposed to keep revisiting, right? three things in metabolism that you have to keep revisiting in terms of pathology are your familial dyslipidemias and A beta lipoproteinemia, your glycogen storage diseases, and your lysosomal storage diseases, right? So all your lysosomal storage diseases are very high yield. You get many questions on it. The first thing that you often have to worry about is whether or not there's a cherry red spot. And that cherry red spot would help you pick between Tay-Sachs and Niemann-Pick. And of course, Niemann-Pick is the one that has hepatosplenomegaly. Right? Tay-Sachs does not have hepatosplenomegaly. So that's just really one of the physical exam ways of differentiating between the two. But of course, Tay-Sachs also has the onion skinning, right? This hexosaminidase A deficiency, right? So other things can be given. Our patient with the lipid-laden macrophages, hepatosplenomegaly, right, thrombocytopenia, myelonemia, and leukopenia. It's not exactly 100% clear what disease he has, but also the fact that it's more prominent in Ashkenazi Jews, right? We're between Gaucher, Niemann-Pick, or Tay-Sachs. It could really be any one of them. Gaucher is the most common, so since they gave lipid-laden macrophages and Gaucher is the most common disease, it was pretty safe to assume this patient has Gaucher. Fortunately, all three of the diseases, regardless, are autosomal recessive, and that's all you really needed to know to be able to finish the question. Alright, this question had a lot to talk about, right? Because reproductive is a pretty difficult topic for many people. There's a lot happening. Many people don't often spend a lot of time in reproductive because there's just so much to talk about in the pathology section, from all your sex chromosome disorders to sexual differentiation disorders and so on and so on. It's just endless pathology in reproductive. Our question, let's take a look at it. So 150. A normal appearing 17-year-old girl has never had a menstrual period. I want you to understand right now that when you read a question like this and they tell you that someone is a boy or a girl, it's pretty meaningless, okay? In today's time, in 2020, we have this, whether you like it or not, and I don't like it, you have this sexual identity thing where people can identify as a gender other than what they were born with. So if a question tells you that this is a girl, it doesn't necessarily mean this is a genetic girl. This could be a normal appearing 17-year-old XY patient, okay, that never had a menstrual period. But they tell you it's a girl because then you can understand the physical features they're talking about. So breasts, right, and the entire shape that a female body tends to have is there for the 17-year-old girl, but she never had a menstrual period, which means she's missing some internal organs. The vagina also ends blindly and no uterus or ovaries are palpated, okay? So immediately you can now figure out, if you've studied enough reproductive, what went wrong. A buccal smear shows chromatin negative nuclei, right? What does that mean? There's no chromatin in the nuclei. That's a giveaway, right? What does it mean? What chromatin are they looking for? So with females, right, if this was actually a girl, then as a girl, right, you are supposed to have two X chromosomes, of which one of them gets hypermethylated and it becomes what's known as a bar body, right? That is what they were looking for. They're looking for bar bodies, okay? They did not see any bar bodies in this patient. The lack of bar bodies in this patient means that she is actually an XY, okay, XY. So being XY, you can now understand that this is actually a boy, right? Which of the following is the most likely diagnosis? So why does this boy look like a female, right? Have a vagina that ends blindly, no uterus or ovaries. Something didn't occur. So now, how do you figure this out? The answer here was just A. It was androgen insensitivity syndrome. This boy didn't become enough of a boy and ended up looking more female than he should. And it's because he's not responding to the androgens. On the top I've written, this patient has no bar bodies, which means this patient is XO or XY. Turner syndrome would have a uterus and streak ovaries and not be normal appearing, right? Turner syndrome patients, those females do not look like a normal female. So you would not pick answer choice C, Turner syndrome. Congenital adrenal hyperplasias appear much earlier, right? Those symptoms present much earlier, and you have to master all 3 congenital adrenal hyperplasias based off of where the arrows are pointing, right? So you have 21, 11, and 17. The arrows I'm talking about are the number 1 in each one of these diseases, right? Which talks about GFR, and you have to remember that in all congenital adrenal hyperplasias, the F is not exactly something you care about, right? So let's take a look at real quick congenital adrenal hyperplasias. The F is always, right, because this is an adrenal hyperplasia where the adrenal gland is not necessarily doing its job correctly. There's no cortisol, right? So F is always low, which is why I just X it out. There's no fascicular activity at all. These numbers, 21, 11, and 17, are talking about the G and R. So in 21, there's a lot of R. In 11, there's a lot of G and a lot of R. And then in 17, there's just a lot of G activity. That's all this is. That's like the easiest way to memorize all your congenital adrenal hyperplasias. But this is not what our question is about at all, because all of these things, as you should know already, present at a very, very young age. Pretty much infancy, right? Pretty much infancy. So it's not something that's relevant to our patient who is already 17. And the one last thing that you would keep in mind is 11 is pretty unique because you actually don't make any aldosterone, but the 11-deoxycorticosterone that you do make, because you have enough of it piling up, right, because of 21 activity, 11-deoxycorticosterone and even 11-deoxycortisol, these guys act much more like aldosterone. Even though it has corticosterone in its name, it acts like the sterone, this part, which is aldosterone, not tisone. Okay, so super easy stuff. But again, none of these things are relevant to our patient, right? What happens when you have too much, like for example, 17, the arrow pointing up, right? You have too much mineralocorticoids, no sex hormones. No sex hormones means no testosterone, so that's going to mess up any guy, and the guy would be born with ambiguous genitalia and undescended testes. But we don't have that in our question, right? The other one where you have too much hormone, too much testosterone, that causes virilization in females, which we've already established. Our patient is not a female. And the same thing in 11, too much testosterone, female virilization, our patient is not a female. So is our question about 17 alpha hydroxylase deficiency? No, it's not. So it couldn't be answer choice B either. Prenatal exposure to excess androgen, prenatal exposure to excess estrogen, don't really make sense. This is straight up androgen sensitivity syndrome. The medulla of undifferentiated gonads gives you the testes if you have the XY sorry gene. Testes secrete testosterone from Leydig cells and Mullerian inhibiting factor from the Sertoli cells. Testosterone then causes the Wolffian duct to give you internal male genitalia, and 5-alpha reductase produces DHT for external male genitalia. Mullerian inhibiting factor stops the Mullerian duct from giving the internal female genitalia. That didn't occur here, right? This patient does, it did. Mullerian inhibiting factor did occur, my bad. It did do its job because he doesn't have it. He doesn't have any uterus or ovaries, okay? So MIF did its job. The cortex of the undifferentiated gonads gives you the ovaries if you have XX and no sorry gene. Ovaries then go ahead and make all the estradiol and all that, and you get all your female stuff. Problems in these things that are being discussed at the bottom, problems here can be due to a lack of MIF in a male, leading to a male having both male and female internal genitalia, which our guy does not have, or due to a lack of 5-alpha reductase, leading to a lack of DHT, so the man will lack external male genitalia until he grows up and makes more testosterone. And that entire stuff is discussed as well in its own page in reproductive, but it's not exactly what our problem is either. That's not the issue our patient is kind of undergoing. So that is discussed. Let me find it real quick. Even earlier, I believe. Anatomy somewhere. Was it? No, it's not in biology. Let's take a quick run through. Oh yeah, it is embryology. Okay, right here. All right, so this page, sexual differentiation in embryology, tells you about those two issues, right? Not making Mullerian inhibiting factor because you don't have Sertoli cells, or not making enough DHT because you don't have alpha reductase. Those two issues, as you could tell, are on the male side, right? And our patient is a male, but no matter what, you would be on the male side where there would be testes, there would be internal male genitalia. That occurs. The only other thing to worry about is a lack of external male genitalia because of no alpha reductase, or the presence of this stuff, internal female genitalia, right? Because you didn't make any MIF. Our patient is a normal appearing female. As soon as you're a normal appearing female, the issue could not be any of those things that are right here. So the only answer to the choice to pick was androgen sensitivity syndrome. And let's take a look at that as well under pathology right here. Right, so there's something that they didn't give, which is very specific to androgen sensitivity. Defective androgen receptor resulting in normal appearing female, right? Normal appearing female, but it's actually 46XY. Female external genitalia with scant axillary and pubic hair. This was not given, right? No axillary or pubic hair is a pretty big deal for you to understand androgen insensitivity syndrome or diagnose androgen insensitivity syndrome. Patients will have high testosterone, estrogen, and LH because they're trying to make the hormones they're supposed to be able to. Although male, they get raised as if a female. Breast development occurs thanks to aromatase in the adipose, making estradiol, and all of that aromatase activity is succeeding because there's no counter testosterone activity. Testosterone, you have no sensitivity to it. AIS is an X-linked defect of the androgen receptor. Masculinization won't occur because you have no androgen sensitivity, right? So full-on androgen resistance. All those testosterone you're even making has no effect on you. The lack of pubic hair is very significant and differentiates this from other conditions like Mullerian agenesis, where the 46XX patient looks the same, right? Just like this, a normal appearing female, but has pubic hair and is actually a female, 46XX. But Mullerian agenesis means that everything that's supposed to come from the Mullerian tube won't form, okay? Very, very important topic. It takes a lot of studying to start mastering all of this stuff that's here. But with enough time, it does start making more and more sense. So, make sure you don't just glance over the reproductive problems. Definitely something that requires a lot of time. 151. A 60-year-old man is brought to the emergency department after being thrown from his car and striking a guardrail in a high-speed automobile collision. Okay, so, and yeah, he didn't have a seatbelt on. He was unrestrained. Physical exam shows blood at the urethromeatus and fractures of the pelvis and the left femur. A Foley catheter is unable to be inserted. Which of the following is the most likely explanation? And this was just urethral disruption. They were really nice to you with the answer choices here too. D. They didn't even make you pick between which kind of urethral disruption. So posterior membranous urethral injuries are related to pelvic fracture, and the urine leaks into the retropubic space, also the Buck's fascia injury space. Would also have blood at the urethromeatus, and the prostate will be higher, right? Anterior spongy urethral injury is another case where, and in this one, blood leaks into the scrotum and the urethromeatus, often related to perineal saddle injuries like a bike bar or dropping onto a fence with your legs spread. And that's pretty painful to even imagine. Those are the other two scenarios that they could have been more specific about, but they didn't ask about that. They were very nice in that manner. Right, so this is discussed right here, urethral injury. Right, anterior spongy urethral injury, because you fell on a bicycle crossbar or fell on the type of a fence or fell on top of anything with your legs spread. That's pretty painful. So of course you can imagine falling like this is going to crush your testes in a sense, and that's what I use to remember that you're going to have blood in your scrotum. Right, you injured the anterior area, blood and urine in the scrotum. You can see how there's blood all of this area. The other one is deeper. It's pelvic fracture related, and that one is due to a membranous urethra, not the spongy one. The membranous urethra being injured, and blood is going to be all up in here. Okay, so very important to be able to differentiate and memorize them and understand them. in any way that helps you. Catheterization is contraindicated in both cases. There's no way you can insert a tube from here and get it into the bladder, because here there's a rip in this area and here there's a rip in that area. The prostate rides higher because once this connection gets torn apart, the prostate goes upwards, right? So you can see how this is the gap. The gap is being shown by this line. This gap was not there before. You see how the prostate is a lot lower, so you can do a digital rectal exam to test the prostate. Here, a digital rectal exam will not feel the prostate. Instead, it'll feel the blood in this area. Right? So those are little anatomical things you want to keep in mind that can be given to you in a question. Okay. 152. 66-year-old man with stage 4 colon cancer comes to the physician because of a 3-day history of severe diarrhea after receiving chemotherapy with fluorouracil, leucovorin, and irinotecan, which is actually one of the medications that the GI team where I work is doing research on. This concoction of medications is still something that has a lot of research undergoing, and of course diarrhea is one of the side effects as well. So the irinotecan, you have to remember, irinotecan or topotecan, you're supposed to keep in mind, I know I can, right? Which is different from etoposide and teniposide, 2 sides to everything. The I know I can is supposed to remind you of the fact that this is a topoisomerase 1 inhibitor, whereas the etoposide and teniposide are topoisomerase 2 inhibitors. The physician prescribes an opioid antidiarrheal agent with little or no ability to produce CNS effects, even when given in relatively high doses. So CNS effects, basically they're saying is that this is an opioid antidiarrheal agent, because opioids are all medications that cause constipation in general. This is an opioid antidiarrheal agent that will not cause addiction and will not cause pain relief because it has no CNS symptoms. Which of the following was most likely prescribed? So you can immediately knock out any one of these that you would give to someone for pain, which means it could also cause addiction, and that's all of them except for loperamide, right? And I know this from studying this, but if I was doing my research job back then, I would definitely know it because we give it to our patients. They come in telling us they're having diarrhea, and loperamide is something they're already prescribed. Anytime they're feeling like, it's going to be a diarrhea kind of day, they take the loperamide, slow down their gut motility. Loperamide is an excellent medication that UWorld asked many questions about, AMBOSS asked many questions about. Very high yield opioid medication that has no CNS penetration. So you'll never see a question where someone was using loperamide as opioid abuse, right? It's not a thing. This drug is discussed in GIT rather than in neurology because it has no neurological pharmacological properties, right? It's only got GIT properties of causing constipation as a therapy for diarrhea. Very nice medication. The other one you want to make sure you really know, the other very high yield medication here is buprenorphine, right? Is orphine, so an orphan, and has no family to be a part of. That is a story you're supposed to use to remember that it's a partial agonist. It's an orphan. It's a partial agonist. It doesn't have a complete family. Notably, buprenorphine has low efficacy but high potency, so it can even prevent other opioids from binding. Hence, it can act as an opioid antagonist in the presence of full agonists and cause withdrawal symptoms. And that's something that's a huge pharmacological, physiology kind of thing that you can get questions on. Very important topic. Codeine and morphine are full agonists that junkies would always abuse. Hydrocodone is a synthetic opioid. Again, same thing can be used, right? Codeine, morphine, you always see questions on it. Hydrocodone is just another similar thing. So, not a bad question at all. This is a great question. This is something you're supposed to be able to describe. When you study biostatistics, everything in biostatistics is stuff you're supposed to be able to talk about without the book in front of you. Very important. So if someone asks you what happens to sensitivity in PPV or specificity in PPV or NPV, any of that stuff, when you raise the cutoff point, when you lower the cutoff point, what happens? You should be able to answer that with no issues whatsoever. You could use a story to remember that. For example, what would happen if we took diabetes as an example, right? Let's say that right now the diagnosis for diabetes requires you to have a resting fasting blood sugar of 150. Let's assume that's standard, right? So anyone above 150 sugar is diabetic. Okay. So now let's say we raise the cutoff point to 1,000. So now I'm saying only people with blood sugar over 1,000, so like 1,100, those are the people considered diabetic. So now I definitely increased one thing, which is specificity, because anyone that gets a positive result definitely has the disease, which means I also increased PPV, right? Because PPV is exactly what I just described as well. But I lowered the other stuff, right? Because the negative predictive value is not going to be that good. People who have 900 sugar are no longer going to be considered diabetic according to my cutoff point, because that's just how my new test works, right? And that's something you can use. You know, stories like that, examples like that are great ways to memorize stuff and understand stuff. This is another similar kind of thing. So let's take a look at it. 153. A 48-year-old man is referred for evaluation of possible hypertension. On the basis of 10 measurements, the patient's average diastolic blood pressure is 113, and the standard deviation is 8 millimeters mercury. Okay. If 4 rather than 10 measurements of the mean blood pressure are made, which of the following is expected to impact, right? Which of the following is the expected impact on the size of the 95% confidence interval about the mean blood pressure? Right, so this question will either go completely over your head the first time you read it, or it will make complete sense to you and you'll know what's happening. A lot of that has to do with your experience with math. A lot of it also has to do with your experience of working with similar kinds of things. So they're decreasing the number of measurements, which you can think of as decreasing the size of n, right? The sample size is decreasing. So if you decrease the sample size, right, what's going to happen? That's basically what they're saying. Because originally they had 10 measurements. Right, so originally they had 10 measurements, and they got an average of 113. So those 10 measurements on a line going from, like, what is this? This is blood pressure. So let's say they're doing systolic blood pressure, right? Systolic blood pressure. And maybe it's on a range from like 90 to 180, let's just say, right? So some people might have, and they got an average of 113. That means of those 10 values, let's say 113 is like, where's 90 to 180? So something in between would be like 135. Okay, so the 113 we're looking for is somewhere over here. Okay, that's our average of 10 measurements. So that means the 10 measurements they got, right, many of those measurements must have been like right here somewhere, right? And then maybe there was one that was over here, but majority of them must have been like right here. That way the average got tilted to in this direction, and you got 113. Now imagine I cut out many of these measurements I did, right? So I cut out some of these measurements that I did. Just remove a bunch of these guys, right? But we keep, maybe by mistake somehow we keep that one, or we keep someone else that's right here, right? We're coming down to 4 rather than 10 measurements. By coming down to 4, right, what is going to be the effect on the mean blood pressure now, right? Which of the following is the expected impact on the size of the 95% confidence interval? So they don't even want to know what occurs to the mean, actually. They just want to know what's going to occur to the 95% confidence interval. So to answer this question, you needed to know what is the concept of confidence interval. You don't even need to remember the equation or how you calculate it or any of that stuff. If you just knew what the concept of a confidence interval is, you would be able to answer the question and pick C. It would increase in width. Your confidence interval would be much bigger. Another way to answer this question is something like fewer measurements, the confidence interval gets wider because you need a larger sample size for more valuable results. Confidence interval is something like if you have a bag full of red, let's say you have a bunch of like beans in a bag, right? And this bag has 50 beans total. 50 beans total in this bag, and maybe 40 of them are red, and 10 of them are green. And you're not going to be that confident in picking a green one at this point, right? But you'll be pretty confident in picking a red one at this point. Now, if the number of beans were removed from here, right? And maybe it came down to just one bean or two beans. Your confidence interval of knowing whether or not you're going to get a red or green bean becomes even worse, because the chances are, right, the picking the green bean especially, the chances are that those two beans that I left are probably red. I probably removed all the green ones. My confidence interval, generally speaking, which you want to remember, confidence interval, generally speaking, will always decrease if you, or not decrease, worsen. Confidence interval will always worsen if you lower your sample size, right? I think we all, generally speaking, understand pretty well that sample size, we want it to be high, right? We want a big sample size. Nothing good is going to come out of lowering sample size, right? That's like a general statement that we all understand. Now, if you did remember how to calculate confidence interval, then you would see that the n over here, which is the denominator, is going to be part of this, the plus or minus part, right? The plus or minus part. And if you make the denominator smaller, if you divide by a smaller number, you make the number bigger, and the plus or minus would be bigger. So you're going to increase it in width. Yeah, so again, two different ways of answering this question. Either know the concept of what is the confidence interval, what does this shit even talk about, or remember the equation. Two different ways of answering this question. And you can see in this equation, when you type it out correctly with the, if you replace the SE with this SE right here, this is actually what SE stands for, standard error. It's the standard deviation divided by the number of subjects raised to the, or the square root of the number of subjects. If you lower n, you're going to increase standard error, and that means you're going to make the confidence interval wider. And the opposite is also true. If you increase the sample size, you're going to make your standard error smaller, and your confidence interval will also be decrease in width. So something like plus or minus 1 is great. But if you give me a value and you tell me it's plus or minus 100, well, that basically covers all the numbers in the spectrum, and it's a very useless information, right? So that's like actually one of the many and major reasons you have to do experiments or trials with big sample sizes. Okay, so that's 153. Next question, 154. 75-year-old woman comes to the physician's office because of poor concentration and decreased energy for the past month. For 6 months, she has been waking up at 4 a.m. and been unable to get back to sleep. Okay. Physical exam shows non abnormalities. Which of the following is the most likely cause of the sleep disturbance in this patient? All right. So poor concentration, decreased energy, right? Waking up at 4 and not being able to fall back to sleep. Narcolepsy is always being asleep, right? Daytime sleepiness. You can definitely knock out B as an answer choice. Paroxysmal nocturnal dyspnea is actually a whole different thing, right? So paroxysmal nocturnal dyspnea, it's a dyspnea, waking up, like I explained right here, breathless awakening. And that can occur in people who have heart failure, because blood starts backing up into their left heart blood starts backing up into the heart, into the lungs, causing difficulty breathing, and that awakens them. We don't see any reason for her to have heart failure. They didn't give anything like that. So you can knock that out. Sleep apnea. Sleep apnea would be more so something related to pulmonary hypertension, snoring, obesity. They didn't give any reason for us to think of sleep apnea. So you could either pick major depression, which can definitely be a thing here. It's a very old woman, 75 years old. And depression often presents atypically in elderly people, right? And the other answer choices don't make sense. Periodic leg movements doesn't make sense at all. Everyone has periodic leg movements during their sleep. We move a lot when we're sleeping. Doesn't mean you wake up and can't fall back asleep, especially at 4 a.m. That's way too early. Right? So major depressive disorder was the most likely answer choice you could pick. And if you look it up, this is terminal insomnia. Terminal insomnia. Once you wake up, you're awake. Seen in depression and normal aging. So when an old person comes into your clinic and there's a potential, you think that this patient might have depression, you can just give them the questionnaire and they'll honestly fill it out. Or you can ask them, how are you sleeping? Are you doing the things you used to enjoy doing? How's your concentration? Do you have energy for stuff? And of course, you rule out all the other differentials like thyroid problems, anemia, any of those other things, right? So very easy and good question. Not a big problem there at all. This one was one that had a trick in it. So 23-year-old woman develops persistent sneezing each year in the spring. Right? Persistent sneezing each year in the spring sounds a lot like either allergy or asthma. Either one. Could be allergies. Her sneezing worsens when she works in her garden. A drug with which of the following mechanisms is most likely to be effective in treating this patient? Answer choice A was a trick answer. Histamine H1 blockers, which are discussed in respiratory pharmacology. Histamine H1 blockers would be good for allergy, but choice A is a bait, right? H2 are your 2 for dining, table for 2. That's the GIT medication, right? Famotidine, cimetidine, all of that stuff. So A was definitely not a potential answer choice. Inhibition of phosphodiesterase is not going to be something you really do. We don't really have any medications where we do that. You can use phosphodiesterase. Phosphodiesterase inhibitor, the only thing we really think of for inhibition, and we do it, but not for this kind of respiratory stuff, the only place you do that with is basically Viagra or pulmonary hypertension, right? And that's not something this patient is presenting with. So we don't do inhibition of phosphodiesterase when we want to fix something like allergy or asthma. Stabilization of lymphocyte membranes is completely irrelevant. Why would we care about lymphocyte membranes here? Stabilization of mast cell membranes. Again, that one looks a little more relevant. Mast cells are related to this kind of symptoms of sneezing. Stimulation of beta-2 receptors, again, irrelevant. Why do we care about that, right? So this patient needs cromolyn sodium. That's the medication you give to someone who comes in like this. Anyone of around this age coming in with symptoms just like this patient, you just prescribe cromolyn sodium, send them home, they'll be all right. This drug actually prevents mast cell degranulation, which they basically reworded by saying stabilization of mast cell membranes. Okay, mast cell degranulation is prevented, and it can help in acute asthma symptoms. It can also help with allergies of this type. She has like seasonal allergy, right? But nothing insane happening here. The other answer choices just truly did not make any sense. (156). This was a really nice question on NRDS. So, female newborn delivered at 26 weeks gestation is found to have hyaline membrane disease. All right. And if you don't know what they're talking about when they say hyaline membrane disease, then you immediately feel like a little lost. She's intubated and mechanically ventilated. Her vital signs are continuously monitored, and inspired oxygen is maintained at a level that will sustain an oxygen saturation between 92 and 95. The primary goal of this treatment is protection of which of the following structures? So then you have to think of, this is a newborn that is needing intubation and mechanical ventilation. What condition would a newborn need intubation and mechanical ventilation for? That would be neonatal respiratory distress syndrome, NRDS. What are complications of giving oxygen to a newborn with neonatal respiratory depression? So let's take a distress syndrome. Let's take a look at that in our book. There's a couple issues that can pop up with neonatal respiratory distress if you don't treat it correctly. All right, so neonatal respiratory distress syndrome, NRDS. Take a look at what occurs. Therapeutic supplemental oxygen can result in retinopathy, intraventricular hemorrhage in the brain, and bronchopulmonary dysplasia. So that's why the intubation and mechanical ventilation has to be monitored and done in a very controlled way to prevent damage to the retina here. Right? The other answer choices are not related to the rib mnemonic we just looked at. right? Retinopathy, the ventricles of the brain, or bronchopulmonary dysplasia. None of those are here. Only the retinal one. That's it. Okay, diabetic ketoacidosis. Obviously a very high-yield topic that'll also be on your test. 35-year-old man with diabetic ketoacidosis has a decrease in plasma glucose from 900 to 270 during treatment with insulin and volume repletion. Good, that's what you're supposed to do to help someone. Why do you get diabetic ketoacidosis in the first place? Because you didn't take your insulin. Which of the following additional lab values is most likely to decrease with insulin therapy? So then at this point, this just becomes a question about anyone getting insulin and the mechanism of action of insulin. What does insulin do? So you look at all your answer choices, and the only thing that will be decreasing in anyone you give insulin to is serum potassium concentration. That's the only thing. In diabetic ketoacidosis, there is increased acid in the extracellular space. Transcellular shift due to decreased insulin leads to more H plus entering the cell in exchange for potassium. Right? This leads to hyperkalemia with depleted intracellular stores of potassium. There is also osmotic diuresis that leads to increased potassium loss in the urine and total body potassium depletion. The question asks what is most likely to decrease with insulin therapy. Serum potassium concentration will decrease as potassium will now be exchanged for the H plus inside the cell, fixing the acidosis and the hyperkalemia aspect. Insulin increases cellular uptake of potassium as well as amino acids. You gotta know that. Additional UWorld fun fact regarding potassium and DKA: use caution giving insulin and IV fluids to a dehydrated hyperglycemic because insulin forces potassium in cells, causing fast decrease of extracellular potassium. So you have to give potassium supplementation as well. Of course, they didn't mention that in the question because that would have given away the answer, right? Given away the answer. So you have to remember that when you treat diabetic ketoacidosis, you give insulin, you do volume repletion, and you also give potassium because the insulin will decrease serum potassium and it can worsen depending on how bad it was already low. Okay, so very important concept right there. Great topic, but very easy to get things wrong in this topic as well. 158, a 7-year-old girl is brought to the clinic in a developing country where lack of adequate good quality protein has been identified as a critical issue. Right, so they're in some developing country. She's at the 70th percentile for height and 90th percentile for weight, which are pretty, on the higher end, especially the weight part. For a developing country, she's pretty overweight. Vital signs are normal. Physical exam shows no issues. Which of the following amino acids is most critical in the analysis of this child's diet at this time? So this is kind of related to your right after amino acids, they talk about all those diseases, right? Let's go back and look at it real quick. So in metabolism, after you're done talking with glycolysis and gluconeogenesis, then you do the urea cycle, hyperammonemia, then you look at your amino acid derivatives, and you have all these diseases, right? All these diseases, PKU, alkaptonuria, even the maple syrup urine disease stuff, right? All bunch of stuff happening. Starting with phenylalanine right here, right? So you look at your answer choices. Let's go back. You don't have phenylalanine here. Okay, that's fine. You have alanine, aspartate, glycine, methionine, and tyrosine. You should know quite a bit about each of these pretty well. Glycine, for example, is extremely important. Now, of course, memorizing your amino acids isn't the hardest thing. Where is it? Where did they talk about it? The amino acids are discussed. Oh, right here. Right? Memorizing this stuff isn't the hardest step. First of all, you know your acidic ones are all aspartate and glutamate. Easiest ones to remember, right? The basic ones, his lies are basic is a great way to memorize it. So I love this. His lies are basic: histidine, lysine, and arginine. And also keep in mind, we know because we did this earlier in my biochem videos, right? In molecular, arginine and lysine, you have to remember histones are large. The L for lysine and the Rh for arginine. So lysine and arginine are all over the histones, right? Which means that histones, right? Histones bind negatively charged DNA, so these guys must be very positive, right? And they are very basic. Arginine is the most basic. Histidine has no body charge. Okay, fine, no big deal. Anything outside of these are your other guys, right? So ketogenic, leucine and lysine, you have to remember because those are the guys you give for PDH deficiency. Very easy to remember them. Everything else after that is pretty glucogenic. And I met his Valentine is also a very nice sentence that helps me remember methionine, histidine, and valine, which are glucogenic. None of those things that we've talked about so far are supposed to be the answer. So you can knock out whatever you can knock out, and that takes out methionine for sure. Tyrosine is not exactly an essential one that you would pick as an answer choice, so that goes away. But, oh, wait. Methionine, there's something special about, because that's actually the answer here, right? There is something special in methionine. Take a look at it. Not only is this the only glucogenic one, right? But look at all the answer choices that this one has, right? Because it's part of the essentials, right? Phenylalanine, valine, tryptophan, threonine, isoleucine, methionine, histidine, leucine, and lysine. When you study this, right, this essential section, I said it the other way around. Everything we were talking about up here, the ketogenic, the his Valentine, these are all part of your list of essential ones. The ones down here were not. So anything acidic, you never consider essential. Anything basic, you never consider essential, because these guys don't necessarily have a big play for your answer choices. For example, you see how histidine is here, right? And histidine is written here as one of your essential answer choices. It's almost never the answer choice on your test, though. Histidine is never going to be there, because if it is, it's pretty easy to pick for the most part. But it takes some time, it takes a little bit of time to memorize which ones are essential, for example. But if you look at this, all these amino acids that are listed here, it's really just a list of answer choices to kind of intimidate you, right? Because you look at your answer choices, you're like, alanine, do I know this one? Aspartate, do I know this one? Do I know glycine? Like, what are these guys even for? Depending on how much biochem you studied, you get more and more intimidated as you go through these answer choices, and then you lose it. Now, the mnemonic private Tim Hall doesn't exactly help that much. It really doesn't. Met his Valentine reminds us 3 of those are glucogenic, right? The met, the his, right, and then the valine. So you can definitely remember met, his, Valentine are the glucogenic essential guys, okay? Leucine and lysine are the purely ketogenic ones, and those 2 are right here too. Those are also essential. So those guys, the valine, methionine, histidine, leucine, and lysine are the easiest ones to remember. Those are your easiest essential amino acids. Amino acids that are essential means that you have to ingest them. Your body cannot make them. Okay, so very essential amino acids. The other ones, phenylalanine, tryptophan, those 2 you have to remember because you study it right here when you look at this table. Right, from right here, right? Phenylalanine gives you all of this. So you know for sure phenylalanine is extremely important, and you can now remember that it's essential. Tryptophan is very important when we were looking at pellagra, right? With the niacin deficiency, and of course serotonin comes from it. So it's another guy that's very important, and of course, obviously, essential, okay? Who is not essential in this list, but is pretty important? That's our guy glycine. Okay, glycine is not essential. Glycine makes blood. The way you can remember glycine is not essential, even though it is important. It's important, but it's not essential, because your body can make it. And the way I try to think about it is we make blood ourselves all the time. So I just want to imagine glycine is something that you can make, right? Just a simple way of memorizing that. Glycine is not something you have to eat. Your body can make it. So that's not your answer choice here, right? So you can just knock that out because it's not essential at all. You can easily remember phenylalanine and tryptophan because of the significance that we have over here. right? As well as over here, phenylalanine, right? Big deal. And then where tyrosine is considered, tyrosine is not. You see? Why is it not? Because you can make it. You can make it from phenylalanine. Right? So without phenylalanine, you might not have much tyrosine there, and that's the actual problem. But tyrosine is not the essential vitamin. Sorry, essential amino acid. Okay, tryptophan is, phenylalanine is. And who else is left now? Who else is left? Phenylalanine. Oh, back to my thing. Phenylalanine, valine, tryptophan. Okay, threonine and isoleucine. No real way of memorizing them. I always pair isoleucine with leucine, but the only thing is you have to be careful. Isoleucine is not ketogenic like leucine is. So that's one thing you have to keep in mind. The threonine, I don't really know any way of memorizing it, to be honest. But, you know, you play around with it. You spend time with it like I did just now. A couple minutes I've been talking about this for this question. Spend time with it. Hopefully you'll remember enough to be able to answer the question on your test. When I did this question, when I was taking the test before I made the explanation sheet, I was able to pick methionine because I remembered the sentences. Met his Valentine. All of them are essential. Leucine and lysine, purely ketogenic, used in PDH deficiency, and are essential. Phenylalanine and tryptophan, very big guys, very important guys, many derivatives from it, and they're essential. Okay, phenylalanine and tryptophan, these two. The others, you know, I had no idea what I would do with this guy, aspartate. Alanine is part of ALT, alanine aminotransferase. The liver uses it, not what we're looking for here. Glycine, I also remember because, of course, it's here for porphyrin. And when you look at your porphyrin ureas and all of that, you see glycine over there too. Tyrosine is not essential. You can use where is it? You can use phenylalanine to make tyrosine. Your body can make it, so it's not an essential one. Okay, good question. Very good question to test you on it. Definitely a slightly harder question depending on how much time you spent on biochem, but it's all about time invested. Time invested in coming up with methods. So met his Valentine, leucine, lysine, isoleucine, phenylalanine, tryptophan, definitely essential. You have to eat them. Threonine is the only one that's hard to remember. It doesn't really fit the scenario. There's nothing special about threonine, but if any of you know something, feel free to shoot me an email and I'll start, using that. 159, clearly a farm question right here. And if you do, I always like just, doing a quick browse at the answer choices, unless they're long answer choices, but like, little answer choices like this, like this stuff, any of these little answer choices, I like to do a little semi-browsing of them so I know what I'm looking for in the question. 72-year-old man comes to the physician because of a 2-week history of non-productive cough. He has non-Hodgkin lymphoma treated with a variety of anti-neoplastic drugs. Physical exam shows hyperpigmentation around the elbows. Chest x-ray shows diffuse infiltrates. Okay. So he's got a non-productive cough, non-Hodgkin lymphoma, diffuse infiltrates in chest x-ray, hyperpigmentation. Which of the following drugs is the most likely cause of his symptoms? So chances are he's taking one of these medications that causing the cough he came in with, right? Because his diagnosis is given. His diagnosis is non-Hodgkin lymphoma, right? And is being treated with many drugs. Today, he's coming in with something that's most likely a side effect of one of those anti-neoplastic drugs. Whichever anti-neoplastic drug we're thinking about must be causing pulmonary symptoms, okay? His physical exam showing hyperpigmentation could also be part of the same drug side effect, okay? Now, which drug do we pick? So, bleomycin, carboplatin, chlorambucil, prednisone, vincristine. Of these, the two you should immediately be able to knock out is, first of all, prednisone. Definitely can't be. This is not, first of all, prednisone is not an anti-neoplastic drug. It's just a corticosteroid. Prednisone can be something that might possibly cause some level of hyperpigmentation in someone at some point or whatever, but that's definitely not a medication that fits the scenario here. And then you can knock out vincristine if, when you studied your anti-neoplastic drugs, you remember vincristine crisps the nerves. It causes peripheral neuropathy, not some kind of chest lung issue, pulmonary fibrosis, basically, right? Vincristine doesn't cause that. Chlorambucil, if you don't remember the medication, you leave it there. Carboplatin, same thing. If you don't remember the medication, you kind of leave it there. And then bleomycin, you have to remember, bleomycin blows up your lungs, right? It's on chemotoxman too. So let's go take a look at it real quick. Knowing your chemotherapeutic agents are, it's something that takes a little bit of time. But, you know, if you have experience working with patients in some kind of cancer department, that really, really, really helps. Otherwise, bleomycin is a very special medication. It's the only one that works exclusively at G2. It's a very special medication, right? Double check repair. Bleomycin works right there. And when you look at it, bleomycin can cause pulmonary fibrosis and hyperpigmentation with minimal myelosuppression, which is beautiful because most chemotherapeutic agents cause a lot of myelosuppression, which leads to more problems. Okay, so bleomycin is a medication you can use for testicular cancer, right? I also remember bleomycin blows up your balls, bleomycin blows up your lungs, right? And that's how I remember you can use it for testicular cancer. And then in the book it says it's for Hodgkin lymphoma, and our question is treating non-Hodgkin. You can use many medications to treat all kinds of things. It's not, you know, written in stone that you can only use a medication for just that one thing. So don't fall for that. That's not something you want to really worry about too much. Doxorubicin, daunorubicin, we just talked about earlier. It's the D of ABCCD for things that cause dilated cardiomyopathy, right? And you can use dexrazoxane to prevent that. Always got to remember all the preventative things that can prevent side effects. There's many of those things. Later on with cyclophosphamide, you learn about Mesna, right? Mesna is something that can prevent the bladder cancer side effect or hemorrhagic cystitis side effect of cyclophosphamide. Got to keep that in mind, right? Taxanes are a big deal. So remember, taxa stabilized society, cells are going to be stuck in metaphase, preventing anaphase, hyperstabilization of your microtubules. Vincristine and vinblastine, they both do different things. Vincristine crisps the nerves, vinblastine blasts the bone marrow suppression, peripheral neuropathy, right? Very easy to memorize these. Cisplatin was another answer choice in our question. Cisplatin, as well as carboplatin, oxyplatin, all these platinum agents, right, are very interesting medications that also have a preventative thing called amifostine you have to give. They are used for testicular, bladder, ovary, GI, lung, many cancers, right? GI and lung cancers, there's many different types. So these medications can be used for all kinds of cancers, but one major side effect is the nephrotoxicity. Then it can also cause peripheral neuropathy and autotoxicity, but you can prevent this major side effect by giving amifostine, a free radical scavenger. All right, as well as, of course, drink a lot of water, do the chloride saline diuresis and all that stuff. But amifostine, Mesna, and then the other one we just looked at right up here, dexrazoxane. These are all preventative, additive medications that you give to prevent the side effects of anti-neoplastic medications. Gotta spend time, master it. Not easy, but totally doable. So just keep in mind here, always knocking out answer choices is very critical. Very critical. Last question for this video. You look at this here, you think maybe this is going to be something microbiology, pharmacology, right? 26-year-old man with HIV comes to the physician because of a 3-day history of generalized reddening skin involving the palms, arms, legs, and soles. Okay, so that's already a big deal, right? Not many things in microbiology cause a rash, right? The reddening of skin in the palms and soles. A rapid plasma reagent test result is positive. RPR is, generally speaking, a thing you use for syphilis. It could be a false positive. Treatment with which of the following antibiotics is most likely to eradicate the causal organism? Well, since this thing is causing a rash in the palms and soles, we immediately know, given the positive RPR, it must be syphilis. And the only way to treat syphilis, no matter what, always got to remember that, and I put it in the explanation, is penicillin. Even if the patient is allergic to penicillin, the only way to treat syphilis is penicillin. You desensitize them to penicillin, and then you give it to them, starting at a lower dose and then getting higher and higher. Yeah, anti-cancer drugs are hard to memorize, but you take time with it. You definitely take time with it. You have to enjoy medicine. That comes without saying. And experience is the best way to memorize and understand these things. Ever since I started doing my job as a clinical research coordinator in the oncology department, all these medications are starting to become secondhand. So that goes to show and prove the more times you look at something, the more times you apply something, the more easy it becomes, right? Use it. Think about these medications regularly in your head, apply them regularly in your mind, make cards if you have to, right? Doctors don't ever forget medications because they're out there prescribing them all day. Students can forget them because we look at it for like 10 minutes, we study it, and then we never look at it again until it pops up in a question or we sit down to study it again, right? But other than that, we don't have regular studying of one thing, and of course that's not our fault. We can't just sit there and study one thing. But as I said in some of my videos where I talk about study advice, every day there should be at least 3 to 5 things you master, and you could pick a day to master cancer drugs. You could totally pick a day to master cancer drugs. Know what part of the cell cycle it affects, because you can get questions where they give you the cell cycle and your answer choices are going to be A, B, C, D, and E, and you have to know where that medication has an effect. And especially invest a lot of time getting your anti-metabolites down, because these guys have a lot of effects on proteins and DNA synthesis, so a lot of it goes back to molecular and cellular sections of biochemistry. Make the connections where you're studying too. Don't just study one thing. So that's something that I have to make videos on to help people understand with good ideas that they can go ahead and apply how to study different things, right? I'm going to be doing that eventually. I'm still putting that together, and once it's nice and ready, I'll put that into action and teach it to you guys. So that's it for now. Great session. In the next video, we'll go on to question 161 and knock out another 20 questions. Thank you very much for joining. Keep studying hard, guys. Feel free to email me anytime about whatever you have. I have a lot of emails right now backed up that I'm going to go ahead and answer. And then I'll see you guys again later. And yeah, I will be doing NBME 24 as well eventually. Thank you very much, guys. See you later.